Thank you very much. I also want to thank you once again, Manas and Manas. And I agree with Frank that 2 years is a very long time, but I'm happy to be here. I'm going to answer this question as good as possible. Cotman, already in 1934, described that the frozen shoulder was difficult to diagnose, difficult to treat, and difficult to explain. And I think some of these statements are still present. He also described that there could be a slow onset inability to sleep on the affected shoulder, with pain at the origin of the deltoid, with limited and painful elevation and external rotation, without any significant radiologic findings. So actually already in 1896, Duplay was the first to recognize pathologic disorders of extra-articular tissues as possible factors responsible for stiff and painful shoulder. His belief was that it was an inflammatory process of the subacromial bursa that was the causative agent producing this syndrome. My own experience with the frozen shoulder is the classical one is a sudden onset with very severe pain, but I agree with Duplay that they can have a slow onset as well after long-standing bursitis or tendinitis. So the definition of the frozen shoulder is it's inflammatory condition with a progressive fibrosis of the joint capsule with an unknown pathogenesis with global temporary decreased active and passive mobility in the glenohumeral joint without X-ray findings other than osteopenia. That's on the longer term. And the symptoms is severe, often constant pain with either a sudden onset or weeks to months after a minor injury or overuse. The prevalence is about 2% of the population. It's mostly female. It's mostly middle-aged people. The non-dominant arm is more commonly affected than the dominant arm. There's an increased risk with diabetes, especially type 1. Also, patients with Dupuytren's contracture, hypercholesterolemia, and thyroid disease are prone to this disease. Diabetics has a 5 times increased risk of developing a frozen shoulder. Also, stationary jobs seems to be predisposing. There are numerous classifications of the frozen shoulder. These are some of them. Lundberg's from 1969 is an etiological classification. Reeves is probably one of the most known. The clinical stage classification. Navasia described the arthroscopic classification, and recently Isakos Shoulder Committee made a new classification about the stiff shoulder. The stiff shoulder is a bit, I think, we have to think about the frozen shoulder, I think, as a disease and not as a condition. Because you have so many differential diagnoses to a stiff shoulder, like arthrosis, maybe a split head fracture, posterior dislocation of the shoulder of the glenohumeral joint. You can also see this after infections and with heterotopic ossifications. Then you have the pseudo-stiffness, pain, just like Frank just described. Sometimes the calcifying tendinitis patients actually looks like a frozen shoulder. This is the known Reeves classification, just describing the stages from phase 1, where the pain is severe and constant. Then you have the phase 2, where still pain but increasing stiffness. And we all want to get the patients into phase 3, where you only have the thawing phase without pain, and the shoulder will gradually thaw. Then Navaisa described the 4 stages of the arthroscopic presentations. In the stage 1, it's as an impingement. Stage 2, as seen on the right, with a red angry thick synovium. And then pink synovium in stage 3 with a contracted inferior fold, tight joint space. And in stage 4, no evidence of synovitis. That's the last thawing phase. Pathophysiology, Lundberg described no signs of inflammatory cells, which is strange when you think that corticosteroid has a very dramatic effect on this disease. He showed fibrosis and fibrodysplasia. Bunker could prove that it looked like a Dupuytren's contracture with diffuse capsular fibroplasia, thickening and contracture, and also showing collagen nodally with dense infiltrations of fibroblasts and myofibroblasts. So I have to answer this question, is it really a surgical problem? I think there's at least 2 or 3 answers. As a consequence of surgery, it may be a problem after a number of procedures, such as slab repair, acromioplasty, that leads to poor results or additional surgery. In my practice, many of the acromioplasty stiff shoulders, maybe it's just about 5%, comes from very aggressive physiotherapy much too early. So I let the patients go very easy the first 6 weeks, no resistance exercises. Or if they fall on the shoulder or something happens. Then as a disease, I think it's a surgical challenge rather than a problem to select the right frozen shoulder patient for surgery. And then I think we should still think that stiffness after rotator cuff repair is beneficial, especially if it's gradually going away. So I think pain is the enemy. Refractory cases difficult to treat may end up with surgery. We see secondary stiff shoulders after slap repair, acromioplasty, cuff repair, and capsulorrhaphy. So treatment can be multi-sided, many of them conservative. These are some of the evidence-based treatment, and NSAIDs for 4 weeks significantly reduces pain but does not affect mobility. Some uses prednisolone. This is not something I use in my practice. We should be concerned about the serious side effects. Then cortisone injections, very commonly used, reduces pain for 4 to 6 weeks. And I think you should repeat it after 4 to 6 weeks if there is still pain. The evidence of physiotherapy had been described here. In phase 1, only light exercises don't hurt the patient any more than they are on beforehand. Phase 2, the goal is to limit adhesions and improve range of motion. And then in phase 3, when the patient is pain-free, you can make joint mobilization and improve strength. In Cochrane review for 2014 showed no significant effect of manual treatment and exercise therapy compared to other non-operative treatment modalities. Shockwave has been shown in some studies to be a significantly better pain reduction than oral steroids. Then you have some options of invasive or operative treatment. The suprascapular nerve block is not very common. Sometimes the anesthesiologists use it instead of an interscalene block, but in this case it has been shown it's better than placebo and cortisone injection. Hydrodilatation is an old method that improves pain scores but no difference in range of motion. Manipulation under anesthesia, I think many of us do this. It has a satisfactory result on short and long term, but we should be aware of the possible permanent damage described by Löw in 2005. 12 out of 30 patients had iatrogenic lesions after MUA. Then the classical one is the arthroscopic release. This is a paper from Geros with a 360 degrees capsular release with good results after median 36 months. Snow showed that in a randomized study that a more simple anterior and inferior capsular release produces the same result as a 360 degree release. So this is just a typical picture here. The median glenohumeral ligament is very, very thick. This is the first I have to cut here. And then we just continue down just before the axillary nerve. Sometimes you can use a meniscal scissors, sometimes you can use a vaporizing instrument to do synovectomy and release the ligaments. My own experiences, I think pain relief is the primary goal for these patients. I think you cannot affect the length of the period they have this disease, but if you can get them pain-free for most of that period, they will be very happy patients. I think pain may be the main factor in developing the frozen shoulder. 1 to 3 cortisone injections has a dramatic effect in over 80%, and physiotherapy is rarely indicated in the painful phases. If no effect of non-operative treatment, you should go for an arthroscopic release with acromioplasty and synovectomy. There are different stages of the disease. In phase 1, if you have no effect of cortisone and analgesics, the patient is very bothered with pain. I think there could be an indication. Then in phase 2 and 3, again, if the patient think that it's a problem, you see no progress. And then you should ask yourself, can you actually get a faster result with surgery? The average recovery time is about 6 months. So if the patient is going into phase 3, getting pain-free, you cannot do this faster with surgery. I'll skip this. So Cotman had a classical dogma said that there's a complete recovery within 2 years. Is it still valid? Schaffer in 1992 said no. Actually, at median 7 years, 50% still had pain and restricted motions. Whereas Griggs in 2000 said yes, 75 patients were followed for 2 years and 90% reported a satisfactory outcome. They found that patients with more severe pain and functional limitations before treatment had relatively worse outcomes. In conclusion, is it a surgical problem? I think there's a relatively high prevalence of postoperative stiff shoulders with a prolonged course. that may result in persistent disability or secondary surgery. So we should, all the normal surgeries, we should treat them well the first 6 weeks so that they don't get into a more painful state than before the surgery. And then there's a good evidence that arthroscopic release has a high success rate in selected individuals, and often these are the worst cases. Thank you very much.